Good afternoon. Thank you for the kind words. And it is indeed my pleasure to really introduce the concept of palliative care.
I think yes, the audio is visible. Can you just
Now can you hear?
this is
Okay. Yes, this is right. No, this audio is okay.
okay, ma'am. Okay, perfect.
Mm. So I'm actually very happy to be introducing the concept of palliative care for this new session batch of students, nursing students. And I would also like to know the participants are all like experienced nurses or students now. Uh, SK, what is a group of people who are
Uh,
attending this today?
Sangeet, if you could just give an update on Sangeet totally, roughly, how many of them are
Ma'am, there are
senior or go
43
ahead.
43 participants. They are all registered nurse and senior as well. Many of them have more than 3 years plus nursing
Okay, so
careers.
experienced people are also there in the group.
Yes, ma'am. Yes, ma'am.
And some freshers might be also there.
Yes, ma'am.
Okay, thank you, SK. SK, you can be running my presentation.
Sure, ma'am. Sure.
Yeah, we are in the presentation mode. And thank you, ma'am, for introducing me. And my first slide I dedicate to Dr. Cicely Saunders or Dame Cicely Saunders. Without mentioning her name, no nursing session in palliative care should start with. So rightly, I put her picture in the first slide. I wish to introduce her to you all because she is the one person whom we should all feel proud of. During the Second World War, in fact, this Cicely Saunders, she studied philosophy and politics in Oxford University, but her interest was in helping people who were suffering. And so, what she decided, like you all, she decided to become a nurse, and then she wanted to help lot of war victim people during the Second World War. And even after doing lot of help and personally she's physically involving in helping patients, she felt that she cannot reach out to many patients. Then she decided to do social, like what we have MSW. There was a profession called almoner post. So she got trained for that, and she was into social work also. Then she still felt it is not adequate, and then she got herself trained as a physician. She became a doctor and she started practicing palliative medicine. She is the main reason for us to have this modern hospice setup, and with her it started the modern hospice movement. She started. You can see the picture of the hospice on the right hand side. Next slide. So again, this is Dr. Cicely Saunders on the right hand side when she was 8 old. So what are the concepts or her contributions to our healthcare? So what she founded was basically, as I told you, she is the founder of the modern hospice movement. And in 1957, she studied pain control in advanced cancer. When she was working in St. Joseph's Hospital, lot of cancer patients were there, and she closely monitored every single patient who was benefiting with what kind of treatment, how much of pain relief they are getting from each approach of treatment. By by studying many number of patients, she published lot of things also. Small in all the local journals, she kept publishing her work also. Then she found out just by treating physical pain, we cannot conquer the pain. We cannot give symptom relief to all patients. We should have a total aspect, total holistic care aspect. That is how the total pain concept came into use. So what all she proposed was physical pain primarily what we are treating, psychological pain, social pain, and spiritual pain. All these four aspects should be addressed. Then only the symptom control will be achieved in any seriously ill patients or patients with life-limiting diseases. Okay, so the one other contribution what Cicely Saunders did was she pioneered the opioid by the clock concept. What we know now as WHO pain ladder, some basic concepts of that was already developed by her. Okay, so if you are already working in palliative care or if you are a practicing nurse, You will already know that morphine when we write as morphine 10 mg, 6 a.m., 10 p.m., 10 a.m., 2 p.m., again 6 p.m., and then 10 p.m. So by the clock, to avoid the next breakthrough pain, to have continuous pain relief. For continuous pain, you have to give continuous pain relief. So this concept was popularized by Lee Saunders. And then she established the St. Christopher's Hospice in 1967 in London, in King's College London, that campus. So what is happening now is that institution serves as epitome of palliative care, and not only clinical care, they do a lot of research and educational activities as well. Okay, so let us move on to what is palliative care. Can we have the next slide? So maybe or may not be, you will be aware of this concept called palliative care. Many people will not know, they would have heard of the name palliative care, but they will not know exactly what is palliative care. It is our responsibility to clearly define and to clearly understand what palliative care is. If you see, I have written as palliative care and SHS. The term SHS refers to serious health related suffering. Okay, it is called serious health related suffering. That's why I put that word suffering in red color, because what we are trying to mitigate is not only the symptom, the suffering caused by the symptom and the disease is what we are trying to do. Okay. So, how do we define palliative care? This is the WHO definition. Palliative care is an approach. It is not always called as a separate field of medicine, like cardiology, like neurology. Palliative medicine is a branch, but this palliative care approach can be integrated with any branch of medicine. With any gynecologist can practice palliative care approach. ENT doctor can, any doctor can practice palliative care approach, and in fact, it's a multidisciplinary. Nurses and psychologists and physiotherapists can also use the same palliative care approach to treat patients and to mitigate the suffering the patients are undergoing. Okay, so I'll read out the definition again. This palliative care approach that improves quality of life of patients. So the end outcome, what we want to have is the patient's quality of life should improve, maybe adult or children and their families. So routinely, conventional approach, when patient goes to the doctor, only patients will get treated. But in palliative care approach, when patient goes to the doctor, the whole family's issues will be addressed. Because of this disease, how is a family being affected? So it is a holistic approach, including the family also. And then family of the patients who are having life-threatening illnesses. We will come to know what are life-threatening illnesses in the next few slides. Coming to the next part of the definition, palliative care, previous slide guys. Palliative care prevents and relieves suffering through early identification and impeccable assessment and treatment of pain and other problems. Everywhere we always try to tell that pain as a significant symptom because it is a commonest and distressing symptom. Other symptoms can also be there which needs our attention. Whether the problem can be physical, psychosocial, or spiritual, the suffering has to be mitigated. That is the goal of palliative care. Next slide. I hope by now you all understand what is serious health-related suffering. So serious health-related suffering is suffering as a result of some life-threatening or life-limiting diseases. Okay. What are the key principles of palliative care? In 2 slides, I have just put the key principles of palliative care. After these two slides, let us have, because it's a small crowd, let us discuss with some few question and answers. So pay attention to this slide of principles of palliative care. This is very important to understand. So palliative care provides relief from pain and other distressing symptoms. Even nausea can be a distressing symptom. Somebody who is continuously vomiting, if, for example, somebody has esophageal cancer, and he's continuously not able to eat, he's only vomiting, that is a distressing symptom. Constipation can be a distressing symptom. Bleeding per rectum for a rectal CA can be a distressing symptom. Even dementia and patients uh, being in distressed state is also distress to not only to the patient, to also the family. So palliative care provides relief from pain and other distressing symptoms. What does palliative care affirm? It affirms life and regards dying as a normal process. Not every time the conventional approach doctors take dying as a normal process. Many doctors think dying as a failure of their medical treatment. But in palliative care, we always ensure that every best possible care is given, and despite of that, if dying happens, it is taken as a normal process. So what we should basically understand is palliative care intends neither to hasten death nor to prolong or postpone the death. So this is a very important thing each and every one of you should know. We are not going to prolong death or we are not going to hasten. Hasten means quicken. Okay? We are not going to do neither of the two. Not hastening death or we are not postponing death. We are regarding dying as a normal. And palliative care integrates the psychological and spiritual aspects of patient care along with the physical aspects, as I have told you before. And what does palliative care offer? It offers a support system to help the patients as well as the family to live actively as possible until death. So it doesn't mean that only for bed care patients we are going to give palliative care. Only for bedridden patients we are giving. It is not like that. From the day of diagnosis or early stage of the disease itself, when there is more suffering, we can introduce palliative care approach at that stage itself. If there is any doubt in anything I tell, you can please stop me and we can go back and discuss what it is. Okay, next slide. The next key principles of palliative care is palliative care will offer a support system to help the family to cope up during the disease and after the disease. Even after death, we call something called like bereavement meetings. During the disease also, we will be walking along with the family. We will be sharing, helping the people to handle the grief if they have lost their loved ones. So during bereavement also, we help the family to cope up. And then very important thing is palliative care will use a team approach. We always have a multidisciplinary team. It is not a single man show. Not only doctor cannot do palliative care or only nurse cannot do palliative care. Doctor needs nurses and the team needs physiotherapists, psychologists, psychiatrists, physical medicine doctors, volunteers, family is also included in the team. So it is a team-based approach only. And then what is palliative care enhancing? It always enhances quality of life. The ultimate outcome of palliative care is improving the quality of life. Okay. The last one is palliative care is applicable even in the early course of illness, not only in the late course. So now nothing can be done now. So only patient has to go to palliative care. That kind of attitude need not be there. When there is suffering, even in the early part of the disease, we can still start palliative care approach at the beginning of the disease itself. It can be given along with chemotherapy, radiotherapy, or whatever treatment is going. For stroke, for example, disease-directed treatment will be going for the patient. Along with that, we can give palliative care together. So if it does not mean that palliative care, if you are doing, you cannot do other treatment. It is not like that. Palliative care will merge or will integrate with the other basic treatment, whatever is going on for the patient. Okay. So these are the key principles of palliative care. If you have any doubt or any thoughts, anything coming to your mind, you can please ask now so that the next slide I just had put some few questions for you. If any of you wants to unmute and ask.
That's what they can either unmute and ask or you can type in the chat also. See, the chat box is there. So if anyone wants to type in the chat box also, you can do, or unmute and ask as Dr. Punitha has mentioned. Either way, or raise your hand anything is fine. Sangeet, you also keep an eye on the chat box, and I will also keep, so that anything we can bring it up. Always, it's nice if you have an interactive session. So no need to have doubts and have them all the time. Better to clarify then and there.
If there are not much doubts, anytime we can stop. We'll go for the question and we'll see if some interaction comes up with the question. Now the question is, what is the chief aim of palliative care? What is the goal or primary outcome of palliative care? In the last few slides, I told you that. Okay. If anybody want to volunteer, you can unmute and volunteer, or I'll give the options. Okay, I'll give 4 options, or we'll see what can be the answer. What is the chief aim of palliative care? This is very important to know. Okay, next, give the option A. Let's see. Is the chief aim of palliative care to cure the illness? Curing illness? Is it to prolong life? Or is it to hasten death? Is it to improve the quality of life? Okay. Now we'll stop there. We have got all the options here. Okay. I think somebody has already
answers are also coming up on the chat box, Punitha. Some have typed, many have typed D.
Yes. D. All of you have got the right answer. Yes. Bharti, Mamta, everyone, all of you have got the right answer. As we have rightly put, D is the only right answer, because to cure the illness is not the only reason we are giving palliative care. Curing the illness will be the primary doctor's responsibility also. We will be not standing in the way of curing illness. We will in fact support that. But that is not the whole and sole purpose of palliative care. We are here to see the patient as a person, as a whole person, including the psychological, social, and spiritual aspect. We are not only restricting ourselves to physical aspect. And as I told you before, palliative care does not only prolong life or does not hasten life. It doesn't do both of them. Okay? And then it is the primary outcome. What we expect is to improve the quality of life. And treating pain is a subset of it. We are treating pain, we are treating symptoms, but that is not the only motto of palliative care. Very good. So we'll go to the next slide now. The answer is B. Yes, this is the next important concept I want to tell you about palliative care delivery. Any care delivery will have multiple approaches. We can do this palliative care in a big hospital, like where I'm working, a teaching hospital, in a small district hospital, in a town hospital. How Pallium India is doing home care, we can do that also. There can be a standalone hospice also. Like in other countries will have lot of hospices. In our country, it is still coming up. Not so many, but still we do have hospices. So PC can be delivered in many places. How do we deliver? In a multidisciplinary approach. What is multidisciplinary approach? People belonging to different disciplines. Some will be doctors. Doctors will be also belonging to different streams. Some nurses will be there. Pharmacists will be there. Psychologists will be there. Psychiatrists will come and go on call. Neurologists may come and go on call. Social workers will be there. As I told you, volunteers will be there. So, family people will be having some roles in delivering palliative care. We will be training the family people also to support the patient. So, every team member will have a separate role and responsibility. What a doctor will be doing is they will be diagnosing the cause of the symptom. We'll see what is the primary curative team will be handling the cancer or the disease per se, and the palliative doctor will be handling the symptom. Or they will be discussing what is happening with the symptom, what is the reason for the symptom, What is causing the distress? How can we handle the distress? We will make a management plan. And the nurses or the pillars of providing palliative care, they will be helping the doctor in assessing the symptom. It is not only pain, because pain is a commonest symptom, we have put pain there, but in assessing the any symptom, in administering medication, in providing patient education, and coordinating the routine care of the patient, nurses are like pillars. Okay, shall we continue? Okay, then psychologists are important part of a palliative care team. There will be a lot of emotional distress which happens in patients with life-limiting diseases. So we have to have a psychologist in the team so that they help us with counseling and coping strategy. But sometimes, unfortunately, we may not have psychologists, or not all teams are completely equipped with psychologists, but still we should always include psychologists at least coming and going on and off at least if we don't have a full-time psychologist. And social workers is also the next important pillar because to support the patient, we will know how to do physical support, but to do social support, a medical social worker only can give the right plans for us for the patient support and the family support. They will come up with lot of practical solutions, uh, helping with the financial assistance. What scheme will help for this patient? How can I get this patient the social benefits? And all who is going to help us? Social workers are going to help us. They are going to mobilize a community resource for us. They are going to help us, help our services reach to the community. Okay, do you understand? So palliative care is a multidisciplinary approach. It is a co-working place. Every one of us have role and responsibility in that. Okay. If any doubt is there, you can ask. Shall we go to the next slide? SK, next slide, please.
Yes, ma'am.
Okay. So next, I have just expanded few roles of nurses to my knowledge. I might have left something, but to the best of my knowledge, I put few things. Nurses are pillars of palliative care delivery. It is very important to have nurses in our palliative care team. Uh, See, SHS is serious health suffering. Any suffering or symptom assessment will be primarily made by the nurse. Many times, the first point of contact will be the nurse. The nurse will be assessing the patient. Not every time the doctor will get to see the patient first. So the nurses should be trained in good assessment. Then once treatment plan is and all made, nurses will be helping in the medication administration, compliance of treatment of the patient, and they will be monitoring whether the medicine what we have given is adequate or not adequate. Is this medicine helping? It is inadequate or it is more. Such things that nurses will monitor and tell the doctors or tell the team. So if there is any side effects developing because of the medicine also, who is there to monitor just next to the patient is the nurse. Then there are a lot of non-pharmacological, not only medications, as you know how the primary nursing care works, the same way wound care, ostomy care, lymphedema care. These are really specialist areas for nurses to help in palliative care. The nurses are the specialists to do these kind of care. So in fact, we all learn these care from the nurses only. And it is prime important point for such delivery of such services. We should have a experienced nurse in our palliative care team. The next thing is patient education. Who can educate the patient very well other than somebody who is very near and close to the patient? Nurses always have good rapport with the patient. They can understand the patient's moods and how are they doing today and all. So they can easily educate the patient and the family regarding the care. So it is very important aspect of important role for nurses is in patient education also. And then communication and advocacy for palliative care is important for almost all of the team members in the palliative care team. And end of life care is one special aspect of palliative care. It is not like end of life care is equal to palliative care. It is a subset. End of life care is one small portion of the big palliative care delivery system. So we should all get trained to how to provide end of life care. And nurses have very significant role in providing end of life care. Okay, next slide. Now, I have talked to you about multidisciplinary team formation, and I have told about the roles of the nurses in a palliative care team. Let's see how the understanding is. I wish you guys, you could all interact and say some answers for this. Can we have the next one? Next question coming up? Okay, this is a true or false question. First one tells that, oh, you got the answers and okay, PC uses a team care approach. Is it true or false? Can you type in or you can unmute and tell?
True.
Yes, yes, that's right. So palliative care is not a single man show, it is a team approach. Okay, that's true. That's right answer. Can we get the next question? C is synonymous with terminal care. Terminal care means end of life care. Is this true?
True.
Actually, in the previous slide, I told you that synonymous, the meaning a word synonymous means it is equal to. Palliative care is not exactly terminal care, is part of palliative care. Okay, so this answer is false. Not only terminal care patients, even patients who are not terminal care, who can eat, who can go to work, every but they have serious health related suffering, such patients still will be enrolled in palliative care. Okay, I will tell you an example for this. There is one patient, we will call her as Mrs. Yes. The answer is false. Okay, I'll give you an example to make you understand that palliative care is not only end of life care. Palliative care is a big thing, big process which just involves terminal care also. Terminal care or end of life care is one aspect of palliative care. Okay, so there was this patient, Mrs. Yes. She came to me to my hospital in Coimbatore, traveling 120 kilometers from a neighboring town, not even town, a village after the town. Okay, so she had a lung cancer, and her cancer has spread to her to the ribs also. There was pleural effusion on the right side of the lung. After coming to my medical college, okay, did I tell you that this lady was 45-year-old? She did not have any other problem other than this lung cancer. She had breathlessness. So breathlessness and chest pain, when evaluated, we came to know she has got cancer. The pleural effusion was tapped. They put an intercostal drainage tube, tapped the effusion. The lungs started re-expanding nicely. Her breathlessness came down. Her chest pain came down little bit was there. So because she had a rib, metastasis on the rib, for pain I had started her on morphine. After the pain relief, she was okay, but if she stops morphine, she will again get pain because of the rib meds. Such a patient, uh, she, she is just 45-year-old. She had 4 daughters. Out of that 4 daughters, 3 daughters were married. The last daughter is still not married, and this lady is herself patient is only 45-year-old. So she wants to live until the last daughter is married also. Every time she comes to meet me, she will tell that. So she wants to work. She does cooking. Because of the financial status, in taking morphine, she will go for job also. In Tamil Nadu, we have a scheme under government called நூறு நாள் வேலை வாய்ப்பு திட்டம். That means they will give 100 rupees for 100 days and they'll give you small chores of work. Like morning, you can go at 8 o'clock or something and you'll be done by 1 o'clock or 2 o'clock. So half a day's work, they'll pay you 100 rupees for 100 days. So to mitigate the suffering of unemployment, Tamil Nadu government has got this scheme. So this, my patient, Mrs. S, was going for that job with this cancer on morphine. She'll go for the job and come back. Then again, she'll have pain after some time. Then she'll come back to the hospital after 2 months. This is going on for last 1 year. She's not terminally ill. She's not sick. Do you think this patient needs palliative care or not? Now tell me yes or no with this example. Does this patient, yes, Does she want palliative care? So you're right, Mamata. Actually, this patient also needs palliative care. It doesn't mean that when patient is walking, talking, looking nice, no need for palliative care. When patient has a seriously life-limiting disease and it is affecting her everyday life, even if she's not terminally ill, we have to be open to provide palliative care for her. Okay, next question will go. Next question is, easy includes family in the care process. Yes or no, true or false? Will we only talk to the patient and decide the treatment and plan and all, or will we also sit and talk to
True.
the family and understand?
True.
We will, yes, very good. Kirti, very
True.
good. Yeah. So yes, Ankita and Sunita has answered. So actually, we will talk to the family also. What is the situation? How can we plan? What else can be done to make this life better for the patient and for the family also? Okay. So the answer is true. Yeah, good. Okay. Next question. PC. Okay, very good. Okay, then the last question is this. PC cannot be practiced in conjunction with other therapies. That means when somebody is undergoing chemotherapy or radiotherapy or some surgery for cancer, we cannot give palliative care. Is it true or false?
False. False.
False.
That's false. So that
False.
is false. Yeah, you got it right. So palliative care can be practiced along with curative therapy. Proper treatment can be going on for the patient, but still, if the patient has lot of suffering, we can introduce palliative care to mitigate, to lessen their suffering. So palliative care can be practiced in conjunction with
False.
other therapies also. Yeah, very good, Shivani. That's nice. The answer is false. So I think now you got the concept of palliative care. Basic concepts you all have got it right. Now we'll go to the next important aspect of palliative care. Okay. So now I have told you many examples in cancer and all. So you will be always thinking only cancer patients will need palliative care therapy. Who will be in the palliative care ward? Or if I'm going for home care, whom all I can give palliative care? So let us see some examples. Do you have any idea? Any of you know some patients who need palliative care? Can any of you volunteer and tell or put in the chat box? Then I'll start giving some examples. All patients will have benefit PC.
Talk patient.
Yeah, talk.
Stop.
Stroke patient.
Oh, stroke. Oh, okay. Yeah,
Stroke
stroke
patient.
patient. The stroke patients will definitely be
Trauma
benefited by
patient.
injection.
Trauma patient.
Paralyzed patient.
Yeah, paralyzed patients will definitely be benefited by palliative care because the suffering is huge for them. Any patients with life-threatening condition. Yeah, Sunita, you are very right. Any patient with life-threatening conditions, they will be benefiting. Stroke
Trauma
patients,
patient.
yeah, trauma patients, if they have chronic deficits, if they are bedridden for some time, if they are back to their normal life, their quality of life is automatically okay, then palliative care may not be required. If a trauma patient, the severe trauma like head injury, definitely they will be benefited by palliative care approach. Okay, let's see what other examples we have got. So adults with cancer. Okay, next one is child with cancer. So it's not only for adults, for children also. Adults with chronic failure, chronic renal failure. Chronic renal failure is a classic example where the disease will be progressing and progressing. There is no pathway of cure. Either they will be ending up in going for dialysis regularly or they have to wait for a kidney transplant. Sometimes kidney transplant might be possible, sometimes it may not be. But still their suffering will be very high. Such patients will benefit by palliative care approach. Okay. Diabetic foot ulcer. This looks like what is there in a simple wound, we might think, but diabetic foot ulcers, once there is if it starts progressing, if there is no control on the disease process, and they have to come for recurrent dressing, the wound becomes non-healing. The stress on the patient and the family will be very high. The burden of stress is very high. So such patients will definitely benefit by palliative care approach. And another important things like a few of you told stroke and all, no? So paraplegia and all, same way, debility and dementia patients who are many times they'll be bedridden, they cannot understand what is happening to them. They will not be able to tell us if they have pain or they have vomiting. They will not be able to tell us also. Such patients will definitely benefit by palliative care approach. As few of you have mentioned, burns patients with difficult with serious health-related suffering will be benefiting by PC approach. Next one. Yeah, and this example, one of you have already told, paraplegia patients and stroke patients will definitely benefit by palliative care approach. So I have just put some few examples here. There may be something else which we would have missed also. Wherever suffering is there, in such patients, we can always have a palliative care approach because ours is a team approach. We are going to integrate with the other doctors to provide approach. So, and it has multidisciplinary approach. Okay. Yeah. Next slide. Next is an important concept which I wanted to. This is last but one slide, but this is a very important slide. As a nurse or as a palliative care team member, we should all know that to mitigate the physical stress, we have all learned many, we'll undergo a lot of training. But to support our patients in emotional distress, we should know this basic concept. Many of our patients, when they come to us, will be coming to us after the diagnosis of cancer, renal failure, heart failure, or some major diagnosis they would have got. Immediately they will go into depression, they will go into grief. So this Dr. Elizabeth Kubler-Ross, she found out, she studied by seeing lot of such patients and saw their mood variations. How is the grief growing through during the period of after knowing the serious health related suffering, like any life threatening diagnosis comes to a patient, how do they cope up? So the first stage is denial. The second stage is anger. Whatever you talk, patient may not listen to you. They will be unnecessarily getting angry towards you, whatever you talk. But after some time, when they know that practically this is a diagnosis, I have to live with it, they'll start bargaining with their situation. Then after some time, even if they bargain, they know that there no improvement is happening, they might go into depression also. So after some time, even by being depressed, nothing is changing, they might finally come to a acceptance state. This curve will not be for few days for everyone. For every single patient, the time period will change differently. Not for everyone, it will be same. So as a nurse or as a palliative care team member, what should we know? That we should know in which phase our patient is in. Is our patient angry unnecessarily because of the diagnosis what he has said? Is he still grieving? Is the patient's family member who is angry with me because of the stress what they are is this their coping mechanism? So we should think about this. If we know this Kubler-Ross grief cycle, we will know that okay, now they are just coping up like this. In few days they will be okay. They will start understanding. So what is my role? My role is when patient is in denial and anger, we should give the right information and practice good communication skill. In your further courses, they will teach you how to communicate in the better way. What are the do's and don'ts of communication? That will be taught to you. So in the next phase, when they are really in that bargaining stage and not still in acceptance, we should be providing them with emotional support so that they do not become severely depressed. So in the next stage, once they have settled down and they are in the acceptance mode, that time we should give the right guidance and right direction. What can be done for the disease? How much for curative and how well for palliative? So this is our responsibility. The orange color thing given below, no, those three are what we can do for the patient in the particular stage of grief and coping up during a severe life-threatening disease or life-limiting disease. Okay, so this is one important concept. With this, I think my presentation is getting over. Is there any other slide? Okay, can you just yeah, that is the last slide. So that was the important concept I wanted to tell you. I think I have introduced to you what is palliative care, and in-depth discussions will be happening in the further classes. If there is case presentation, we can go. If there is any quick questions, we can discuss.
And there is a
Thank you very,
there is-
thank you very much, Dr. Punitha, for taking us through the concept so well. And I think the question answers would have been really, that's the best way, so that they themselves answered and gave us direct feedback that they have understood the concept. So really nice. We'll give few minutes if anybody wants to ask something before we go ahead with the case discussion. Sangeet, can we come out of the presentation so that
Okay, sure, ma'am, sure.
okay, like as if anybody, like any agreement, disagreement in all what you heard so far, no? So anybody wants to ask anything, please feel free. Because where you can do, to whom can you deliver, everything, all the questions which normally anyone will have in your mind. So all those have been explained and brought forth. So if anyone has any difference or anything you want to, like anything that you are aware or something like that you want to do, you can. And is anyone already working in palliative care, if I could ask? Or is this the whole new batch who are going to start training and doing? No, okay. So never mind. So because it's like it's an
Like
government
any of you have
initiative scheme.
palliative department is there in any of your hospitals? Any
Do
of you
anyone
work in a
have?
big hospital?
So anyone has a palliative care, like at least a department or a wing or something in the hospital where you're all working? No, only is coming up. Because it's a government initiative scheme. That's why all of them have come for training, Punitha. That's what I heard. It's it's an initiative by Haryana, right, Sangeet?
Yes, ma'am. Haryana government.
Haryana government. This is initiative where they are. So they're all from that place.
Okay, so these people are from Haryana.
Yes, the full team is from Haryana.
Okay. So none of the government hospitals in Haryana would have.
So basically, initially they
palliative.
start off training them and then going.
Ma'am,
they will
most
become.
of them are from
Please.
CHCs and PHCs, GS, na? So there is no such departments in these care centers. CHC, PHC and all.
See, slowly in southern part of India, no, they are starting. They have at least an outpatients in some centers. So I think the initiative will go all over India to start that setup with either an outpatient at least. So maybe once all of you are trained, so they may have some option or something in mind. So that could be the reason and initiative for getting all of you trained.
Okay, good afternoon, Dr. Radha.
Yes, go ahead. Oh, Jatin, go ahead. Go ahead,
So,
Jatin.
basically, what is happening from NHM Haryana is these are all the new candidates. The ones who have previously been trained, they are working in setups where there is a palliative care department or where they are providing that services. So now firstly, they are training the professionals, the officials, the CHOs and the medical officers from respective districts where they plan to open these services after these professionals are trained.
I think the doctors thing also is happening. No, I did some session for them. Is that
Yes,
right,
yes,
Jatin?
ma'am. There are medical
Yes.
officers from NHM
Okay. Yes,
Haryana as well.
yes. Okay. Thank you, Jatin. Nice to hear you also. So all of you have heard Jatin also. He is our coordinator. So any link is required, queries on starting, setting up and things. We have got Jatin also. Okay, any burning queries, burning doubts or something you want to ask, you can do now. Or we can go ahead with the case presentation and then do also, because case presentation again is important. Why are we doing it today is that from the next session onwards, when you go into individual aspects, like normally I say A to Z of palliative care, you're all going to know. So in that aspect, when you get there, depending on the topic of the day, you will be doing case presentation. It will be nice because if you bring up something related to that, see, from that point of view, none of you need not think that you have to be in palliative care, okay? Without the label of palliative care, all of you will be seeing these patients, okay? Something related to, okay? You may not be telling us palliative care, but everyone is doing it without designating it as palliative care, okay? So for example, I'll tell you some gastrointestinal symptom. You may get one topic or anything like that. No? Try to bring some pain, GI symptom, anything like that. Bring some case which you would have seen or which you would have come across with that particular symptom and present it so that it will be a very good interactive session for the whole team and for the person bringing it up also. The queries that you will be having, you can all clarify all that. So for that, how to do is what you're going to have today. Okay, go ahead.
Again, good evening to all. Now I am going to present about a patient, Mr. X, 39 years old male patient. He is diagnosed with traumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. Now he is having complaints as like 2 days constipation, pressure sore over sacral and gluteal region, moderate pain over the hip region and urinary leakage also. History of illness, he had history of fall while carrying weight followed by neck. Now then pain and weakness of both limbs and was diagnosed with traumatic quadriparesis on 2015 August month. Then he admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a pressure sore over the sacral and gluteal region, became stage 4. Now history of pain over the hip and wound site for more than 2 weeks. Pain over the hip region is an intermittent burning type of pain. Pain score was 5/10 bilaterally, and wound site having 4/10 continuous throbbing type of pain, he complained. Due to this, sometimes they keep the wound open only. Disturbed sleeping pattern also and decreased oral intake. On physical examination, patient was conscious and oriented. Temperature was 98°F. Pulse was 82 beats per minute. Respiration 20 breaths per minute. BP 120/70 mmHg. Other became within normal limits only. Then about the pressure sore on examination, it was warm and tender and exudate present, tunneling also present on that wound, irregular in shape and a foul smell also. Then treatment and a significant investigation, routine investigations done, the values are listed here. Some important values: serum creatinine 0.9 mg/dl, serum sodium 130 mg/dl, potassium and 4 mg/dl. Psychosocial aspect, it's a 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now his mother is a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wages, her pension and some of his friends. Have taken around 1.5 lakhs from a private finance bank for the treatment purpose. Devotionally, he is a Christian. Now he is unable to go to church. This makes him very sad. This information communicated through cell phone. He says to his mother as like, I don't think I can walk, so please don't spend more money over my treatment. Main concern is pressure sore, pain, and financial problems. Summary, summarizing 39-year-old man with traumatic order paralysis with bedsore present over sacral and left gluteal region stage 4 with pain over the hip region. Discussion point, do we need to provide palliative care for this patient? What are the problems faced by this patient? What all can be done for this patient and his mother?
You can put your suggestions in the chat box, or you can unmute yourself and tell.
It was a very good classic case presentation. I think you should all learn to present cases in like a story like this. Okay, for one, they have answered us yes. Do we need to provide palliative care for this paraplegia patient, traumatic paraplegia? Yes, he needs palliative care. What are the problems faced by this patient?
PC. We need PC.
Yes, definitely. In what all aspects can our PC help this patient? What are the problems for which we can help? He is paraplegic and he cannot move now. On top of it, he has a bed sore and he has pain.
Sore and
Yes.
pressure sores.
So he needs care for his bed sore. He needs care for his pain. He has his pain. Physically, we can see all this. What about the psychological aspect also? We should not forget. Yes, bed sore. Yes, absolutely. So, in the total concept of pain, physical aspect is the primary thing. As you all told, his bed sores needs proper care. And then his pain needs
Need psychological supports to his parents.
as he told, he has told his mother that now I cannot walk, I cannot move anywhere, so don't spend any money on, don't give any treatment for me, like that he's telling. What does that mean? I showed you one cycle, no, like Kubler-Ross grief cycle, how patients will behave in different stages. Now probably he is in depressed stage maybe. In such stages, we should know when to take psychologist help also. If we know some counseling, we can counsel in the right way. We should do it.
Time with your training.
Yeah. Does this patient have any spiritual pain or anything?
Psychological support.
Support we have to do. Yeah, emotional and psychological support has to be given because he looks depressed. He talks like that. He has also told that he's a devout Christian and he wanted to go to the church, but he cannot go. Can we do anything about it? He's speaking to people on phone only. If we can we do anything? Who can help this patient in this aspect? Psychological and emotional support. All of the members of the PC can give, or specially trained psychologists can also give. For social support and spiritual support, if he has told us that he used to go to the church, so if there is a possibility after his physical pain is treated, after the physical pain comes down, after the bed sores have been attended to, once he shows improvement, we should give him an opportunity to get back to his, if we can, through video call, can he do a group prayer? Or can we get his friends or his community, his church community to visit his home once or twice? Like that, we can help. This is also a aspect of peace. Do you get it?
Yes, ma'am.
Good communication. So spiritual aspect and social aspect should be taken care also. And as somebody rightly told, the mother also has to be trained and educated for doing the dressings and giving the bedsore care. She also needs psychological support. So it is such a nice case where and the brother has nicely presented in a way so that every aspect of palliative care has come out. Physical aspect, the bed sore and the pain has come out. In psychological aspect, he has found out what patient is feeling about that, what is patient's insight, what is mother's insight, what is the equation between mother and son. Okay. And then he has also brought about the social aspects, what is the situation of the family, spiritual aspect, what is he enjoying to do, what is the purpose or meaning that he wants to have for his life, how is he coping up, all that aspect has been brought out. So we are not seeing this patient as a patient, we are seeing him as a person. This is what total care is about. Physical care, psychological care, social and spiritual care. So all these supports we are trying to give with our multidisciplinary team. Okay, the last question is what all can be done for this patient and his mother? So I have told most of these aspects. Do any one of you want to add on to these points? Like final thoughts, you want to tell what else can be done for this patient in all these four aspects? Any ideas? We have already discussed all these things. No, I told what can be done for the physical aspect. For the bed sore, dressing has to be done, pain has to be treated, and the dressing has to be taught to the mother also. Bystander education has to be done, position changes, how often the mother should change him, all this patient education and bystander education. The family member education should, caregiver education should be started. That is right, as you told. And then psychological, yeah, changing position and psychological support has to be given. If we are not able to give the right kind of psychological support, we should ask for help from the psychologist or a counselor. And then for social support, and once the patient becomes little mobile and all, yeah, somebody has to keep the
Family member support.
yeah, some Ayushman Bharat scheme and all we have put. No, yeah, that's right. Yeah, rightly told the point that the medical social worker of our team or the counselor of the team will help to see what kind of social support from the government side, if there is any scheme applicable, they will try to bring the funds or opportunity to get treated. Okay. So all four aspects of total care we are trying to do. If we do this, there will be quality of life of this patient will improve than what he is having now. His distress will reduce. The mother will be able to cope up. Okay, so the primary outcome of palliative care will be improving quality of life. So definitely this patient will have improvement in quality of life if we address all these aspects. Okay, these are my final thoughts. Madam, you want to add anything?
You have taken them through very well, Punitha. Anyhow, I think Sergeant, they have something more to this slide. Is that right?
Yes, ma'am.
Yes, they will also discuss, Punitha. Go ahead. Go ahead.
First discussion point was, do we need to provide palliative care for this patient? Definitely yes. As he's in a life-threatening situation, he has a serious health-related suffering. His quality of life is definitely affected due to the illness. Palliative care is not only for cancer, end-of-life situation. It applies to any health-related suffering, and the above patient story is an example for this. Next point was, what are the problems faced by this patient? He has physical issues such as pain, bedsore, urinary leakage, insomnia, loss of appetite, etc. He has spiritual issues as mentioned in the presentation, feeling of being burdened to the caregiver, financial issues, identity issues, foul smelling wound over his body, social isolation, loss of independence, loss of job, anxiety, depression to be ruled out. Last discussion point was, what all can be done for this patient and his mother? Community mobilization for regular visits, fund generation if possible, occasional rehabilitation for the patient and mother, empowering the mother to take care of daily care for him like position change, bedsore dressing, etc. Any respite for the caregiver for few days. Look at the health issues and emotional issues of the caregiver also. Make him feel that he is useful, convey that we care.
Yes, very important. Thank you, Sajan. Exactly, no. The last words, when in the discussion, as we have, Dr. Punitha was trying to say, no, he was telling to his mother, don't do anything for me. I'm only a burden for you. There, you have to pick up that he is depressed. That is his personal point. And then, if possible, we give support and everything. By actions, by doing all that, no, you also make him feel, he himself will feel that it's not a waste doing for him. So that is how we are going to try. You see, all the options and discussions which we have gone through, if we are going to do that, get some support for him, make his mother, teach his mother, educate. This is what is educating the caregivers. So if she is able to do, then she need not go get him hospitalized or pay money for doing dressing. So that is really eased off. And next thing is that you give her some respite care also. So only thing is that, again, coming to, we need team approach, multidisciplinary approach. So see, in the last nearly an hour and 10 minutes, you've had important facts taught to you, you all answered, and then with the case discussion. So important facts and information is provided and reiterated. So they have been emphasized and told that what is important, how to do it, and with the case, always with a, see, why I was telling about case presentation is, this throws light on it, so that you will know when you have some case service. As I said, many of you would have seen something. So now it makes sense. Oh, I can do all this. So it's just not dressing alone. We know that his main worry will be dressing, and because he cannot get up, move, all that. But behind that wound and disease, there is a live person living. That is what you have. It's for all of us to know, because that is what, see, we normally say, what is the difference between disease and illness? Diabetes mellitus. That's the disease. Someone X has diabetes mellitus. What diabetes mellitus does to that X, person X, that is the illness. It makes him unhappy. It makes him depressed. It makes him sad. So that is why we have to treat the illness also. So that is, see, I was telling, see, listening to this case, it'll be an eye opener that every day, if anyone brings up some case like this, you will have more discussion and clarify queries, clarify doubts. Oh, I can manage so well. And even, see, I always in these type of platforms, this is the best place to discuss. Okay, all your doubts, silly, important, not important, never mind. Where more can you discuss? This is a place where you can discuss, clarify, and do better. Like always, our core interest is delivering. Our main interest is in patient's best interest. So always we want to do something good, not only good. I said best, the best. So when you want to do something like that, it's okay if you can, or if you can get the opinion and do more. That's always ideal for the patient. So that is why in the first session as such, we give you an introduction on this so that you can bring up cases like this and discuss and move forward. And see, in this, all the queries and discussion we had. And again, it was told, what are the benefits? Why do we need to do it? How can we do it? And what will the outcome be? And mainly, last thing, if you just those words, if you say, don't worry, we are there to care for you. So that goes a long, long way. See, and also we say, cure may not be possible always, but care can be given always. So these are things which you will all have to remember always, all the time. And it will give better satisfaction to each one of you also. So multiple things are there. That's why this case, don't think it is difficult or something to bring up cases. Please do bring up, and it will be helpful for all of you. And anybody wants to add on anything more, queries or anything like that, please do. Do everyone agrees with the discussion that went around with this case presentation, or is there any different? Because all of you were typing in the chat box. Let me just check anything left in the chat. All what we have discussed on it. So that, see, it was first thing, always good things first. Really very good. Well done, team. Okay. Well done to Dr. Punitha, and well done to the whole participants also. See, it wouldn't be best when there's no active discussion. So all of you were either typing in the chat box, or some also unmuted and answered also. It's better. Keep going in the same spirit. That's what I would say. And as Dr. Punitha was telling, you will have multiple sessions with everything that you need to know about palliative care with nursing perspective. Anything anybody wants to ask, please unmute and ask, or type in the chat box. Anything else, Sangeet, regarding, you have any queries with technical thing, joining, that also please do ask, or you can get in touch with him. But anything particular, being the first session, any queries or difficulties anybody had, please do. No, very good. Thank you, Jyoti. Can't hear you, Punitha. We cannot hear you at all. Now only one word I heard. Please repeat what you were telling.
No, like
now we can hear.
Very important. The first case I presented
Ma'am, your voice is getting
sorry, dear. We can't hear you at all. I don't know why. Maybe are you in a place where the internet is not good?
Now is it okay, ma'am?
Yes. Go ahead.
So my first case presentation was my own grandmother. I did not get any case. I was not working in palliative care at that time. Only all I knew was anesthesia. So 4 years or 5 years ago, the first case I presented was my own grandmother. The symptom I took up was angina. My grandmother was used to have severe chest pains and angina. She had triple vessel disease. 83-year-old she was at that time when I presented the case. So she was on 18 medications, 4 medication for angina. But after I presented the case, I got some clarity. I went back to the cardiologist. I went back to the diabetologist, spoke to them, saw how I can reduce a pill burden for her, for an 83-year-old lady. And I got the confidence that we did not go for angioplasty for her after discussing the case in Palliative platform. So I want to tell the nurses also, you also come up with your own case. Let it be simple case. Let it be in your own standards. It's okay. Nobody is going to judge in this platform. So I wanted to reiterate that whatever Madam told is very, very good point. Bring up some case.
Exactly. I love nothing wrong. Like many times we say, and many people have brought it up also because main thing, no, cancer and non-cancer. We are palliative care is for cancer patients and non-cancer patients. Like chronic renal, chronic cardiac, chronic pulmonary, all add chronic to all system chronic diseases will benefit from palliative care. And for every system, there's one or two. So please do, and that will be very, very helpful for all of you. Don't hesitate. And as she said, this is such a good platform. And as I always say, all of you try to help each other and move forward. And end of the day, what the government is wanting from you is you get trained and train more. And so that this service is available to the person who needs it in one rural place. That is what is the important thing. Okay, so try to bring up cases and things as something related to the topic of the day. Okay, then in that case, if there are no more queries, I will pass it on to Sangeet.
Thank you, ma'am, for the queries. There are some technical queries as well. I will hand over to Sri Priya for the further clarification.
Yes, please.
Dr. Punitha, for joining us today. We know that you are still on duty inside the operation theatre. We know that, and still you found out time to enlighten us with your knowledge. Thank you so much. You are a great friend of Palliative India. Please do so. Keep supporting us with sessions like this. Thank you so much. So, ma'am, I will switch to Hindi because most of the participants at times find it a little bit hard to follow English. Dr. Punitha, if your duty calls, you may kindly leave the session, or else you are free to stay back as well. Because now everything will be technical only.
Okay, then I'll take a leave then. Thank you all. Thank you, ma'am. Bye.
Thank you very much, Punitha. Thank you very much.
बाकी सब लोग मीटिंग पे ही रहिए थोड़ी देर. सबको धन्यवाद आज के सेशन में ज्वाइन करने के लिए. तो मैं थोड़ा अभी टेक्निकल थिंग्स के बारे में बातचीत करना चाहूंगी, क्योंकि ये जो सेशन है अभी बहुत लोगों ने ग्रुप पे मैसेज डाला था कि लिंक नहीं मिला, जूम लिंक आपको नहीं मिला था. तो कृपया ध्यान दीजिए, हमारे जो भी सेशंस होंगे उसके लिंक थ्रू आईए को ही दिए जाएंगे. ऐसा नहीं है कि जूम का लिंक आपको डायरेक्टली हमारी तरफ से मेल या व्हाट्सएप आएगा. जो भी लिंक होगा सेशन ज्वाइन करने के लिए वो आईएको द्वारा आपके व्हाट्सएप नंबर में, ईमेल में और एसएमएस में मिल जाएगा. वो एक ऑटोमेटेड लिंक होगा और यूनिक लिंक होगा, माने हर एक पार्टिसिपेंट के लिए एक यूनिक लिंक रहेगा. अब देखिए मंजीत कौर को जो लिंक आ रहा है, अगर उसके साथ सलीम अली, सॉरी मैं दो नाम ले रही हूँ जो मुझे स्क्रीन पे दिख रहा है. सपोज कीजिए अगर मंजीत कौर को जो लिंक मिला और सलीम अली उनका लिंक यूज कर रहे हैं, तो दोनों की अटेंडेंस कैप्चर नहीं होगा. तो इसलिए कृपया ध्यान रखिए, आप लोगों को आईएको पे रजिस्ट्रेशन करना बहुत ही मैंडेटरी है. अगर आपने अभी तक रजिस्ट्रेशन नहीं किया है तो फिर आप अगले सेशन से आपको लिंक भी नहीं मिलेंगे और अटेंडेंस भी मार्क नहीं होगा. अभी मैं थोड़ा स्क्रीन शेयर करूंगी आपको कैसे करना है, तो थोड़ा ध्यान दीजिए इसमें.